Okay, good evening, everyone. I know some people are still streaming in with their food, but we figure we'd get started so we have plenty of time for questions. I'd like to introduce Dr. Cari Levy. She's a professor in the Department of Medicine and works through the Center for Innovation for the elderly population. She has a interactive talk with us today, so she's encouraging questions and those kind of components as well, and about the kind of continuum of care after the people leave hospitals. So, okay.
Hear me okay? Does that work? So this is your time to learn about nursing homes and really any post-acute care setting that you wish to learn about. So please ask questions. The slides are really just there to help generate our thought about this setting of care. And there's so much going on right now with healthcare reform and payment reform, and there's a whole lot going on in terms of changes with therapy payment in nursing homes, and I honestly don't know if any of us understand the implications of what will happen. And I've asked people who try to understand it, and they don't know. So I don't feel like any of us are qualified to actually talk about those particular implications. But we're going to talk about the current state of things, recognizing that there's more stuff on the horizon. So I would like to start by just hearing your thoughts about nursing homes and what comes to mind. And you can be totally honest with me. I won't be offended. And just your thoughts, random thoughts, free association. Nursing home. Step before palliative care. Absolutely. So about a quarter of all deaths in this country occur in a nursing home, and about 30% of all hospice is provided in a nursing home. Yet if you ask a nursing home provider, tell me about your end-of-life program, they'll say, oh, we don't have an end-of-life program. We have a rehab program, but we don't have an end-of-life program. But you're absolutely right. A lot of end-of-life care is provided, but yet nursing homes aren't reimbursed for that. They actually lose money when they're providing end-of-life care, and so it's a really weird thing because they make money on rehab but not end-of-life care. It's not a lot. It's not a lot. Other thoughts about nursing home?
Put out to pasture.
Oh, put out to pasture. Yes. So that is often a thought that folks think about a nursing home, for sure. Yeah. Yes?
They're officially called skilled nursing facilities or rehab facilities. And so when I started a couple years ago in rehab, all the patients that I would see in an inpatient facility are now it's SNFs for the most part.
Yep.
Unless your spinal cord injury is hitting. So, but they only have like one full-time physical therapist and 5 assistants.
Yep.
Contrasted to larger rehab centers.
Yep, absolutely. So everything's moved, right? So in the nursing home, we've got people who used to be in the hospital or in inpatient facilities, and it's all shifted quite a lot. And the reason I call them nursing homes is because that's what they are. They're nursing homes, and because we're providing a lot of end-of-life care, as was astutely pointed out, and we're not doing a lot of the rehab that we think we're doing, I think it's actually appropriate to call them nursing homes. The rehab that is provided is extremely low intensity. Many of you probably know Jennifer Stevens-Lapsley, who's doing work on high-intensity rehab, and the example that she gives is the 97-year-old who is sitting in a chair doing stand-to-sits, and she told you the story? So she's doing stand-to-sits, and she's using her arms, and Jen says, hey, try it without your arms. And she does it just fine, the 97-year-old, without using her arms. And then they say, well, let's put a vest on you. And they put a vest on, and then they put some weights on the vest, and pretty soon she's doing her stand-to-sits with a 30-pound weighted vest. And she's doing fine, and she's 97, and the therapists are worried about her, but she's doing great. And this is the example that they give in a lot of the facilities that these older adults can actually, they can handle a lot of therapy, but they're really probably very underdosed in nursing homes. So let's talk a little bit about, this is the vision that the facility operators, of course, have. And facility operators have, many of them, a good heart, and they very much want things to work. Most nursing homes are mom and pop. We hear a lot about the chains and how awful they are. And some of the chains really aren't trying to do a good job. They're just trying to make money, and they're not making much, I'll tell you that. Most of the margins are pretty small for these nursing home chains. But the mom and pop ones, we go out and visit a lot of these as part of our research, and we interview these folks, and they really are trying to do the right thing, but they're in an environment that doesn't support success in many cases. And this is what, the bingo ladies, this is often what people think of when they think of a nursing home. And unfortunately, this is what a lot of people think of when they think of a nursing home or when they go to a nursing home, pretty sad environment. So right now, there are many, many things coming together to try to make all the pieces that don't typically fit together, try to fit together in this era of health care reform. They're really trying to make sure that the incentives are aligned so that hopefully the hospital is having the same incentives that the nursing home has, that the home health agency has, and that we're all trying to do a better job and take good care of folks. So this is, an ACO vision where we have people all hopefully working for the same goals, and long-term care has now been included in that. In the past, long-term care nursing homes were always sort of this black hole that nobody wanted to think about. They weren't considered in really any payment model, and then suddenly people realized, oh crud, it's really expensive, and if we're going to start including it in the whole system of care, we need to think carefully about how to do this well. So fortunately for us, there's now some attention being paid on how to care well for people in long-term care and post-acute care. So I had sent along our objectives, but basically we're going to just try to talk a little bit about this environment so it's a little less mysterious. So on the national landscape, there's about 16,000 nursing homes across the country. We have about 250 or so in Colorado. There's about 1.7 million people living in these homes, and 70% are over the age of 65. Most are female, and it's interesting, I work in the VA, so all of my residents are male, so 96% of ours are male, and then I go out in the community and go, oh yeah, that's right. It's mostly female in the community. So the Colorado landscape is, I say 200 here, but we actually have more than that, about 17,000 residents. And there's lots of efforts on this campus. We have a group called the Post-Acute Care Researchers and Team Science, the PAC-RATs, and Jen Stevens-Lapsley, she's doing some work on high-intensity rehab with a community of nursing homes. Rebecca Boxer was doing some work on CHF and had about 48 nursing homes she was working with. And so fortunately, we're building some relationships with some of these facilities and trying to do work. Christine Jones is doing home health work, and so we do have some research efforts focused on this, and this is just our little group at the health department where we meet regularly. These are medical directors of nursing homes who come together to talk about nursing home care and medical direction. So, question for you, who pays for the majority of nursing home care? Is it Medicare, out-of-pocket, Medicaid, private insurance, long-term care insurance, HMOs, PPOs? What's that?
Medicaid.
Yes, it's Medicaid. So we think old people, Medicare, that must be who pays for nursing homes. But it's actually Medicaid. How do you get Medicaid?
Being poor.
You're impoverished. How did you get impoverished?
You spend all your money on health care.
You spent all your money on health care. That's exactly right. So in geriatrics, one of the sad lessons we teach our fellows is the sad reality of the spend down, where somebody has a savings. And for those of you who have walked this walk with your family members, you know this. You had a savings. Your grandmother, your mom, your dad had a savings, and then they had to go into a nursing home. And how much does it cost? I'll probably ask this on a subsequent slide, so you'll be experts. How much does it cost a month to live in a nursing home on average?
$10,000.
It's about 6 to 8. If you're getting if the state's paying, it's around 6. If you're paying, it's around 8. So I usually just say about $8,000 a month. So imagine now that you've saved up, $100,000 or so. That goes very, very quickly when you're paying $8,000 a month for a nursing home. And so what happens is someone goes to a nursing home. They've just had a big, expensive hospitalization, usually that led to the nursing home stay, and so they've got the bills from the the nursing home, or excuse me, from the hospitalization, then they've got the bills from the nursing home, and very quickly that savings gets spent down, and then you are at the poverty level and you qualify for Medicaid. So the majority of the nursing home stays are paid for Medicaid. Medicare covers the rehab portion. So Medicare covers that first 20 days of rehab, and then they'll pay a portion after that up to 100 days. So a little bit there, but because it's only the rehab portion, it's overall a much smaller portion. Okay, so this is the Medicare payment. So from day 1 to 20, the Medicare beneficiary doesn't pay anything, and then after that, they have a co-insurance, and then after that, they're responsible at 100 days for all the costs. So it really does quickly become quite expensive. So who's eligible for a typical SNF stay? Somebody who has Medicare Part A. And how do you get Medicare Part A? You turn 65 and you fill out some paperwork. And what percentage of 65-year-olds manage to get that paperwork filled out? It's an entitlement, so you just have to fill out the paperwork and send it in and you get it. What percent of people over 65 do that? 96% of people. People love entitlements. So if you get an entitlement, you are going for it. Then there's, of course, Part B, which actually costs some money. So many, many fewer people have Part B. C is a managed care product. D is the pharmacy benefit. But anyway, Medicare Part A is that rehab benefit. It also pays for your hospital stays and that kind of thing. But for SNF, you have to have the 3 overnights, and you've all heard this, right? You've all heard about the 3 overnights. And this makes people crazy because sometimes they just have to sit in the hospital for no good reason because we have to have the 3 overnights so that they can qualify for their rehab stay. There are some states that are waiving this. There's some programs that are starting to waive that 3 overnights, and they're doing some demos to understand what's the implication of that. I think ultimately Medicare will do away with the 3 overnight requirement, and we'll have some flexibility with that. And then, yes? I'm pretty sure it was arbitrary. I don't actually know the details, but I've not seen any data that said, oh yes, this is the key. And then the daily skilled services are required for that Medicare stay. Okay, so we're going to talk about a couple, Marjorie and Bill, to kind of go through just some of the nuances of nursing homes. So Marjorie and Bill, 84-year-old female with mild dementia who was hospitalized after a hip fracture. This is Marjorie. And her hospital course was complicated by pneumonia, a new onset atrial fibrillation, delirium, and this resulted in a 12-day hospitalization, so a pretty long hospitalization. And she has new functional deficits that include bathing, grooming, walking, and dressing. So physical therapy recommends a SNF stay. And I don't know if you all know this, but guess who doctors decide that a SNF stay is necessary? You. They say the physical therapists decide that. When we ask you guys, when we ask physical therapists or anybody in rehab, who makes the decision that a person's going to go to a rehab facility, they say, oh, the doctor makes that decision. And then when we ask the social workers who makes that decision, they say, well, the doctor and the therapist make that decision. So none of us take ownership for this decision, but we all think the other person makes this decision. We did some interviews about this a couple of years ago, and there is no ownership for it. I mean, no one is the person that has to say this is going to happen and sign on the dotted line. I don't know what your reaction is to that. Do you feel like you're the ones making that decision that someone has to go?
We're predominantly rehab doctors, and we usually feel like that we have the final say.
You have the final say. Okay. So, because the medicine doctors think it's a physical therapist. Yeah. And do the physical medicine doctors think it's the physical therapist?
No, we think it's us.
You think it's you?
Yeah.
Okay. So, right. So do the physical medicine doctors think it's the physical therapist making the decision? The medicine doctors think it's the physical therapist making the decision. And the social workers think it's the medicine doctors. And the medicine doctors never think it's them, right? Because they have no idea what's going on with the physical therapy piece. So anyway, it's interesting because probably we need some objective measure to say this person needs physical therapy in a nursing home, and here are the things that they're likely to benefit from. We learned from the knee bundle that a lot of people could actually go home and do fine at home with therapy if we pick the right people, but we didn't know who to pick. We don't know who's the right person to go to a nursing home or go home. So anyway, okay, so Marjorie had this long hospital stay. She has new deficits. Physical therapy or the PM&R doc recommends a SNF stay for her. Okay, so Bill says, her husband, says, well, can't she do an acute rehab stay? I hear that will be more hours of therapy, like was pointed out, and she'll get better faster if she does an acute rehab stay. Okay, these are his questions. And he's told, well, she's not eligible. She doesn't have enough endurance. She can't participate in enough hours of therapy, so she can't do that. And then he says, well, you need to scan her head again. She's confused. She's not herself. Can you please do that? And they said, well, we don't really have an indication. We think she's delirious. This is very typical of a hospital stay, so we're not going to do that. And he says, well, she needs more testing for this, and she needs more testing for that. And he's making a lot of excuses, and all the medical testing that needs to be done has been done. And so we're kind of wondering what's going on with Bill. And then we finally say, what's troubling you? And he says, well, I think you're going to send her to a nursing home. And I really don't want her to go to a nursing home. And I don't even know where to start with figuring out which nursing home and what they do there. So he says, what do you advise me? So what do you tell people when they say, which nursing home?
I think we're not allowed to recommend nursing homes as doctors. I've heard that, yeah, specifically.
Okay.
We will almost always say, like, the advice I usually give is, like, try to get it past a full level of quality and then get one that's close to you and whether else you can visit on.
And in terms of quality, what things do you tell them to look for?
Come unannounced.
Go unannounced. Go to the facility unannounced. What else? Yeah, other recommendations you give people about nursing homes? So tell them to go look at the star rating, and then compliance issues. Okay. So, and the patients are usually doing this, or the kids, the family members, sure, are often helping out. Yep, of course. So, so he asks you, which one's the best one in town? Do you guys have one that you like?
What's the best one for you?
What's the best one for you? Yes. Okay. So, so it's hard to know, and of course it depends. And usually people want to be close to their home or their kid's home, so that makes a big difference. And often people are willing to trade quality for closeness to their loved ones. So they'll say, I realize it's not as high quality, but I really need to be so Bill can come visit. Okay. So he says, can they manage all of her medical problems? She's got a lot of medical problems. What do you tell them about this? So there is, I think somebody mentioned this, there's a requirement for one RN in a nursing home 8 hours a day. That's the state reg, or that's the national reg. One RN, 8 hours a day. Often there will be more, but that's the reg.
Not per a certain number of patients, just like under the roof where all the patients are.
So I don't know that we can answer his question very accurately. How long will she be there? How long do you think she'll be there? We said she has deficits in bathing, grooming, dressing. What did we say? What did we say? Let me go back. Hold on.
Does she have Medicare?
She has 4 deficits. She does have Medicare.
20 days.
We're going to say 20 days. Hey, good answer. Oh, shoot, I missed her. Where did I say? Oh, sorry. Anyway, she's got 4 ADL deficits. Okay, so you say 20 days. Anybody else? It depends. Okay, so it depends on how well she engages with therapy. And he says, what can I do to make her stay as short as possible? Well, she's going to a nursing home. Oh, but okay. Okay. Oh, so start preparing for home, like the moment she gets there. Sure, okay. Yeah. Any advice for him while she's there to make her stay as short as possible? Absolutely. So advocate for him. And what's the best way for him to do that? Be there. Be there, be there, be there. The family member who is there, that resident gets a lot more attention than the person who doesn't have a family member there, no question. So that's always good advice. Any other advice you give folks? What's that? Go to therapy, see what she's doing, and then try to help them understand why, maybe she's not going to participate because she's delirious, but if she has a familiar face, she'll participate. Then you mentioned earlier, go unannounced when they were choosing the facility and that kind of thing. So absolutely, so be there, and we're going to talk more about these things as we go. And then he says, how much will it cost? How much you got? So the first 20 days, it won't cost him anything. After that, it'll be that co-insurance we talked about, and then after that, it's about $8,000 or so a month. Will he go bankrupt? Yeah, so we'll go through this actually. He's helping his son recover a business, and he very much wants this money. This is a real value of his, and he's worried he'll lose it by paying for this nursing home care. And he says, is there an alternative? Could he send her somewhere else? Could she go to an assisted living? Could she go to a foster care facility? Is there something else that could be done other than a nursing home? And we'll talk a little bit about that at the end. What's up?
Hire some help at home.
Hire help at home. So how much is that an hour? About $20 an hour for an unskilled person. And if you can cobble together family and other stuff, you can see if that's a better, you can do the math and see if you can afford that more effectively than the $8,000 a month. But yeah, it's about $20 an hour. Yeah. Okay, so let's talk about the best one in town. Somebody mentioned that there are ways to do this, and what's the best way to do it? Go with the social worker's recommendation, make an appointment with the nursing home admissions and marketing director, make an unannounced visit and take a good sniff of the place, have a look at the CMS website, C&D. So going unannounced is a great way to understand what's going on. Go on a weekend and say, I'd like a tour of the place, and see what's happening. That'll give you the best sense of what's going on. And then you can smell it, you can see it, you can understand what's going on in terms of activities and that kind of thing. And then there's this CMS website. So anybody know what it's called? Nursing Home Compare. Okay, so here's Nursing Home Compare, and you can just pull up the nursing homes that are closest to you. You can adjust the zip code or whatever selection criteria you have, and you can pull up the ones that are closest to Bill's home, or you can put in other selection criteria, but it'll tell you all about the homes. So there's the Colorado State Vets home at the top, and you can see that there are different sections. There's one that's on their quality ratings, there's one that's on their survey, and then also their staffing. So you can actually drill down into this and see what deficiencies they got in their survey, bless you, their survey, how they did on their quality ratings and which ones they didn't do well on, and you can really understand a lot about the home. So you see the State Vets home there, and then you've got St. Andrews Village here, and then you've got Aspen Center, and then you can compare these and contrast them.
Do you know how those ratings are made? Like, are they based on someone inspecting them who's qualified to do that? Are they based on the patient's experiences and surveys they've done?
So there's three components. There's one that is the state survey, then there's staffing ratios, and then there's standardized quality metrics that are like, falls and delirium, and did they get a flu shot, and all that kind of stuff. Yep, so it's those three components. The survey is weighted most heavily, and it will kill you. If you get a bad survey, it sticks with you for a much longer period of time, and they have frozen the ratings because they were shifting things around, so the ratings have been frozen for a couple of years. So if you had a bad survey at the time around the shift, you've been dead in the water for quite some time, but they're now moving this along. So here's one that I used to be medical director at. So this is Rowan Community. They have 70 certified beds. You can see just the general information here. They participate in Medicare and Medicaid. And then you can see there's that health inspection data we just talked about, their staffing ratios and quality measures. And this is compared to average. So their health inspection was above average, their staffing above average, and their quality measures much above average. So they got 5 stars on that and 4 stars on the other. And overall, they were 5-star when I downloaded this. So then you can drill down and you can go into their health deficiencies, understand when they had their last survey, look at what those deficiencies were. You can go into the number of residents they have, Colorado's average, the national average, how many RNs they have per day, LPNs, CNA. I mean, you can really get a lot. If you have a family member who really wants to dig into this, they absolutely can. You can see the physical therapy staff hours, less than a minute for whoever asked about that. This actually is a facility that doesn't do a lot of Medicare. It's almost an entirely Medicaid building, so they're not doing rehab, which you can see. They're not doing rehab. But you see the national average there, 6 minutes. So yeah, to go back to what we were saying before. So anyway, that's the best way to pick one, honestly, is to go unannounced and then to do the Nursing Home Compare website. So then the question is, how long will she be there? So we have a little issue with her transition. So Bill picks a facility using that Nursing Home Compare website and going and visiting several. And then she's transferred on a Friday afternoon. Never a good idea, right? So he waits for the physician, and it's late the next evening. He waits all day the next day. And then Marjorie becomes more confused on Saturday evening. And he says that the Haldol, which actually was helping her a little bit, was discontinued when she was admitted, and that the morphine she needed was not going to be available for a while. So guess what? He demands she gets readmitted. So what happened to the Haldol? Nursing homes hate antipsychotics. They get deficiencies for antipsychotics. There's a huge national push to reduce antipsychotics. And so if they see an antipsychotic, whoosh, they take it off the list if they possibly can. So that happened basically in the transition. What about opioids in nursing homes? They have to be ordered by a physician with a handwritten prescription. And imagine how long it takes to get that to the pharmacy, get the stuff back from the pharmacy. It's an incredibly onerous process. And so people often go quite some time without their opioids in long-term care facilities. It's a mess. So it is not surprising at all that this happened. And where was the physician? They are required to see a patient once every 30 days for the first 90 days and once every 60 days thereafter. That is not the standard of care in Colorado. The standard of care in Colorado is a new admission is seen within 72 hours, but it's Friday. She's very unlikely to get seen over the weekend. She will be seen Monday. So Bill was upset, understandably upset by that, but that is the standard. And so she gets readmitted, and we see this all the time, right? So who cares for nursing home residents? So why did this happen? So this is who's caring for nursing home residents, CNAs. That's who's doing the land share of the care. I mentioned this earlier, that there's only one RN required, and then the LPNs are administering the meds. So you'll see the big med cart in the hallway, and then the CNAs are doing all the bathing and the direct care, and the LPNs are really just the medication administering people, and so they're pretty much stuck at the cart. So if there's a change in condition, it would be noticed by the CNA, and the CNA would have to alert the LPN. But we're asking a lot of a CNA. And how many hours would you guess a CNA gets in training? Has anybody been a CNA? Yep. How much training did you get? 2 weeks. 2 weeks. So usually it's about 60 hours. Where were you a CNA? In Michigan. At a nursing home? Yeah. How was that? Really busy. Yeah. You work your tail off. Some of the hardest work you'll do. And do you mind telling us what you got paid? It was like $10.50 an hour. So people, this is what people are living on, is basically $10 an hour, and they're trying to care for a family on $10 an hour. So this is, it's really quite amazing work when you think about it. They're working very hard. They're getting paid very little. We're asking a lot of them. And so this is why family advocacy is essential. And so the more Bill can be there, the better. So here's our challenges. There's extremely high turnover. If you go into a nursing home today and you go back 3 months from now, it's very unlikely you will see the same staff. Turnover is about 94% for aides because of exactly what you just described. They aren't getting paid enough, so they're constantly trying to figure out other things. The LPNs, it's about 50%, and the RNs, it's 59% annually. There's a lot of vacancy, obviously, and there's a lot of competition. So if the nursing home down the road pays 50 cents more, that's huge when you're getting paid $10.50 an hour. So they'll go down the road. You see the salaries there, and of course, if you work in a hospital, you get paid a lot more. So of course, if you can get a job in a hospital, you'll be going to a hospital and not working in a nursing home. So the expectation conversation is what I wish would have happened with Bill, where we said, when you go to the nursing home, Marjorie will not be visited as often as she is in the hospital. The doctors will be available, or the nurse practitioners will be available, but they won't be there, and on a Friday, she won't get seen till Monday. So that should have been established before she left. The antipsychotics are really difficult to justify, so there should have been a conversation between the physician at university and the physician at the nursing home to say, this has helped her. I recognize it's not the best drug in an older person, but she's actually responded quite well to it, and if you could taper her off it, but let's continue it until she's through this delirium. And then 1 in 5 of these folks will be rehospitalized in 30 days because A, they're sick people, and B, there's all this transitional stuff that's kind of a mess. So in terms of length of stay, this is kind of how things shake out. About 20% of people have these short lengths of stay and have a rehab and go home. But the majority of people are there for longer periods of time. So 10% 3 to 6 months, 15% 6 to 12 months, a third are there for 1 to 3 years, and then another 12% 3 to 5, and 12% 5 years, just to give you a sense. Yes?
And those that are there about 3 months, 3 to 6 months, do they die in the nursing facility?
Most of them, yeah. Right, so it depends on what you came in for and that kind of thing, but about 60% of people who go in will not leave. Yeah. So this is a beautiful thing. It looks very confusing, but I like to call it my flying bee. Lisa, have I ever showed you my flying bee? Okay, so this is our flying bee, and what this is it shows different deficits. So bathing, grooming, walking, dressing, toileting, bowel, bladder, incontinence, transferring, and feeding. And so when you start over on this far left, that's 0 ADL deficits, and if you come over here to this final bubble, it's all 9 ADL deficits. And then what you're seeing in between in the yellow B's is the most common trajectory in terms of loss of ADL. So the first is bathing, then it's bathing, grooming, then bathing, grooming, walking, dressing. You see the combination. It's not like every human, of course, progresses through this, but when you take a huge data set and you say, okay, what's the most common combination and loss over time, this is how it all happens. And so, so when we do this, Bill asked how long it would take her to get well and that kind of thing. And so in this is actually the number of days that it takes to recover one ADL deficit, the number of days it takes to develop a new ADL deficit, and then the percentage of people who do that given any combination of deficits. Does that make sense?
Is it a markup?
It is. Why do you know that? So, which one?
Between B and B to C.
Let me blow it up, and then it'll be a little bit easier. Okay, so like here with her, if she's in the middle with a bathing, grooming, walking, dressing deficit, on average, it will take 113 days to go to a bathing, grooming, walking deficit, so to lose the dressing deficit, okay? And 19% of people like that. So does that answer your question? Yeah, so 19% of people with that combination of deficits will recover to one less deficit over that period of time. And so you see, it's not 20 days, right? I mean, this takes time for people to get better. And so we can help estimate. We actually have an app that does this. And we could say to Bill, all right, on average, people like Marjorie, recover in this amount of time. And then he can prepare a little bit. You mentioned, getting the home ready for her. He can begin to plan for that. So on average, it might be as long as 250 days if you've got 2 ADLs she needs to recover, because people tend to do it, in stepwise fashion. And then this is the palliative care slide. So this is once you've got a certain number of ADL deficiencies, the probability of recovering, goes down over time. And some are starting to experiment with. This weekend we had a conference here about setting a research agenda for post-acute care, and one of the people in that group has this nursing home. What is he calling it? Nursing home frail, basically score. And when you meet that score, you basically just need to stop rehospitalizing people and have a hospice discussion. I mean, their outcomes are worse than any metastatic cancer at that point, and it really is a much more appropriate conversation than the let's talk about rehab conversation. Yes?
When you say recovery, does that mean that there's still an impairment, but they might be independent?
It's full recovery. It's full recovery of that ADL deficit.
What do you mean? So, like, walking with a walker, they can be independent, is that recovery?
Yeah.
So could you go back to the previous?
We had to dichotomize it. There are gradations in the scale, but we had to dichotomize it to build the model.
Where'd you make that cutoff?
It was complete independence and complete dependence. Complete independence and complete dependence. Yeah. Correct. Yes. Right. So there's a gradation in there, absolutely. Yeah. That's unaccounted for in that model. Right. Absolutely. And so like in that example, it's what does she need to do to get home? She's got to be able to dress. Okay. So for that one deficit to be recovered fully, it would be this. If it's somewhere in between, it'll be shorter, right? Worst case scenario, yep.
Is there much heterogeneity depending on the diagnosis in terms of how?
We haven't done that. We need to do that and haven't gotten that far. So anyway, as far as this transitional stuff, what could we have done to help this? Having some thoughts some conversations with Bill about what to expect would have been helpful. And if we had been better about indications for medication, some of the work we're doing right now is trying to get the nursing homes connected to Cario and some of the health information exchanges so they can look and see what people were, getting and doing on the inpatient side, because they often, when you're a physician in a nursing home, you often get a med list. You don't get a discharge summary. You don't get any records from the hospital until about 4 or 5 days later. So you're usually working from a med list, and that's it. So it's tough, and that's what would have obviously helped here. So the meds that get people in trouble in nursing homes are, of course, opioids, and then anything that is unusual or needs extra labs like clozapine or any of the procrits or anything that requires monitoring, that kind of thing, will hang people up. So anyway, if somebody's being discharged with something unusual, that will raise red flags and it will be problematic in the long-term care setting. So a couple of other things that when I asked our colleagues, what would you ask of hospital clinicians when someone's being discharged, it was what's the PPI indication, because almost everyone comes to us with the PPI and we don't know why they got put on it, and then it gets held on forever. So if we have an indication and if we can stop it, that's helpful. A stop date for antibiotics, often we get antibiotics and don't know how long those are supposed to go on. If there's anticoagulation, if there can be a stop date, that's super helpful. And then assume that's all they've got is a med list. So if there's anything that can be descriptive on that med list that can help give a clue to that accepting physician about what's going on, that's helpful. And if there's some way to connect with that person and actually give them a name and a number, wow, that would be really something. So there have been a number of programs to try to improve, because I think you're getting the message that these transitions are a mess. The Interact program tried to improve these transitions, and a number of these tools are in use. Unfortunately, this was a big randomized trial of these tools that were designed to help reduce rehospitalizations, and it was negative. It didn't work. It worked in the pilot because they had high-functioning nursing homes. And then when they rolled it out to the average nursing home, they just couldn't do it. They couldn't implement all the pieces of the program. So sadly, we have tools we can use. We don't have any data that they actually help the average nursing home. But one example is this nursing home to hospital transfer form, and it's available, and a lot of the nursing homes will use it, so you may see that come into the inpatient setting. So how much will it cost, and will he go bankrupt? A lot of people worry about this for very good reason. And so we already talked about this. On average, how much is a nursing home? And so there is this allowable income that he will be allowed to keep. So it's spousal protection, basically. So what you can assure Bill of is that he will be allowed to keep enough income to live on, and that he will be able to keep his home and one car. So those are all the spousal protection laws. There's a lot of detail in here that we don't need to go into, but basically, if he had, a certain amount of savings, then he would be able to. He would have to use that, unfortunately, but he could keep his monthly income that comes to him. Anything that comes to Marjorie and has her name on the check goes to the nursing home. So, would he go bankrupt? Because he's the community spouse, he can keep some amount of his assets, but anything that's attributable to Marjorie will have to go to her nursing home bill, and then he gets this allowable maintenance. There's a formula to calculate that so that he can live on, some amount of money and hopefully not, lose his home and that kind of thing. So I set up to one car. This house thing, basically, there are some rules about how much of a house you can keep. Nobody's kicking people like Bill out of their homes. What happens is they have the provision that when Bill dies, they go in and collect whatever amount is owed to that nursing home that the home sold. Let's say the home is sold for $543,000 and $200,000 is owed to the nursing home. That will go to the nursing home, and the state is very good about collecting this money. And then the rest will be part of the sale. So anyway, that's how that works. We don't need to go through all that detail. But anyway, it's there if you're curious. So in general, if somebody's single, they have less than $8,000 in monthly income and fewer than $2,000 in assets, they will qualify for Medicaid. So this is sort of that impoverished thing we talked about. And then Medicaid will pay for the nursing home. So some of you are sitting there thinking, oh, well, I have an idea. I'll just, when I get to this point, I'll just transfer all my assets to someone else or to my kids or something. And so that's what Bill's thinking. Oh, yes, I'll just transfer my assets. Well, guess what? The state's very smart. They won't let you do that. You have to do this well in advance, and you have to do it in a very specific fashion, and it has to be crafted in a very specific way. So there's a lot of detail in here. We don't have to go into it today. But the bottom line is you have to think really carefully about how to do it. And if you try to do it suddenly when somebody gets sick, they'll just go get it. And what's that? Oh, 5 years. It's a 5-year look back, yeah. So is there an alternative? He asked, hey, could I send her to an assisted living? Can I get some home care and try to rehab her that way? So there is this trend that more and more people are trying to, so basically the red is certified beds, the green is patients in certified beds, and then the blue is certified facilities. So over time, there are fewer people going in, fewer certified facilities. So nursing homes are closing. And so what's replacing nursing homes? Other stuff. People are going home. People are going to assisted livings with enormous amounts of care. People are going to foster care. They're doing all sorts of things. This is the median nursing home facility occupancy rate. So it used to be in sort of the 88% range. Now it's getting, this only goes to through 13, but this continues. This trend continues. So it's going down. So nursing homes are not busting at the seams. In general, it depends on what market area you're in, but in general, it's going down. So the reason is Medicaid, as you heard, is paying, and Medicaid is not a robust payer, as you would guess. So a lot of these facilities are operating on a 1% or negative margin, and they just can't afford to stay in business. And so many of them are closing, and I think the prediction is with this new payment model that's about to come out that a good number of one-star facilities actually will end up closing, because there are not only the shifts in the payment model, but there's all of these incentive payments that are being given to facilities with higher performance. The lower ones aren't getting it, and so we're just strangling them. You know, unfortunately, those are the ones that take our people who have dementia and have behaviors, so we're going to be in a little bit of a pickle. And this just gives you a sense of the importance of Medicaid in trying to care for these folks. So the orange is us, so 30 to 40% of our Medicaid spending is on long-term care. So it's a big, big part of Medicare, of Medicaid spending, long-term care. So this is to remind me of the story I already told you, where Jen Stevens-Lapsley was doing the get up and go thing, just to say that there are a lot of efforts to try to figure out how we can do better in getting people stronger sooner. The goals to date have been to make money. And so we do more minutes of therapy so we can make more money and keep these, poor little struggling nursing homes alive. This new model is really, how do we get people home? And how do we get them to not go back to the hospital? So things like high-intensity rehab will actually become really, really important, because it's efficient, takes less time, it's getting people stronger faster, it's getting them discharged more quickly at lower cost. And so it'll be interesting to see how this all plays out in the coming, it's this amazing natural experiment in the coming years. There's also lots of other cool stuff that's happening. I know you're feeling very sad, and I can't let you feel very sad. So I'm going to tell you about happy things now. So the Greenhouse Project is a really neat thing. We have a couple of these communities in Colorado. This is basically taking the big, ugly, institutional-looking, hospital-like nursing home and putting it in these small homes. So these are homes where you have like 8 to 12 people. There is a Shabazim who is overseeing that particular home, and that person is in charge of the meals and the activities and all the good stuff. And then the medical things come to the home. Instead of the medical stuff being embedded in the home and the big cart, lumbering down the hallway, you've got the nurse walking to the home and being a guest in the home. And these greenhouses are pretty neat, and you can see they're just lovely little communities. And then, what's that? What's a Shabazim? A Shabazim, it's just the name they gave to these people who get to oversee the care in this home. I believe it's does anybody know the origin of it? I believe it basically means like kind of a community leader. Yeah. And then Innovage, many of you have seen the cute commercial where all the little silver-headed people are getting on the bus, and it's everybody knows my name, and it's very cute. If you haven't seen it, it will make you smile. But these are the buses you see all over town, and this is daycare. This is adult daycare, Innovage. So they take everybody in their van, they come pick them up in the morning, and there they have everything they need. They've got podiatry, they've got doctors, they've got activities, they've got food, they've got everything, dental, everything you can imagine at this adult care facility, and that's Innovage. Really fun. The last time I went to one, this woman was wearing a crown, and I said, "Oh, what a lovely crown you have," and she says, "Oh, I'm prom queen today." So they had prom, and she was prom queen, and they're very neat facilities. The VA has this program, adult foster care. So this is basically bringing an older adult, just like you would a kiddo who you're fostering in your home. You bring an older adult into your home. And in the VA, you can foster up to 3 people. They get paid $2,500 a month per person in the home. So if you have 3, it's pretty decent, monthly income. It's 24/7 care, and all the medical stuff comes to you. So the therapists, the docs, the nutritionists, the pharmacists, everybody comes to the home. So the person never has to leave for medical care. And the outcomes in this, I've had a paper at Health Services Research. Don't ever submit a paper there ever. It's been there for 14 months. But it shows that it's about $100 a day less in cost for this program compared to, these are propensity match controls in nursing homes. And the thing they're hung up on is the mortality, which If you predicted mortality in this group, the adult foster care group, it was 17% annually. And then it was a propensity matched nursing home group, right? So it should have been 17%. It was 30. And so they're very worried about that. And so that's the 14 months. Anyway, but these were some of the other things we did with this group that showed hospitalizations in the medical foster home group, and it tended to be lower for those folks compared to VA nursing homes. And so anyway, just to tell you that there's lots of innovative things going on out there, and they're caring for really sick people in these adult foster care programs. They have low care people who are, just need some supervision and can't live at home, but then they also have some really high care needs people. I was in one home where they had a young quadriplegic vet, and she was doing all the care, and she also had an older gentleman who had very advanced Parkinson's. And this is, one woman in a home managing these two really, really significantly, impaired folks. So, and then the one I have to tell you about, we were in Oregon, and this woman had 5, because in Oregon you can have 5, ventilator patients in her home. Of course, she had help. She had a ton of help. But in her home, they were chronically vented patients. And it was a beautiful home. It was sitting on a golf course. They all had egresses out to the golf course if they wanted to watch the loveliness going on. And they were extremely well cared for, great outcomes. And so this is the kind of thing we're, starting to see. So Bill makes it through. He gets Marjorie through her nursing home stay, manages to get her back home is the good news, and has some help at home because she's got, still has some deficits. But that's basically the story we wanted to tell today. Okay, done. Questions? We have, I think, 1 minute or something, but we've asked a lot of questions along the way. Other thoughts? Yeah. Yeah.
During the skill phase, 20 days. Is that something that you've seen at the facilities you've been to?
So I haven't seen it in Denver, but we had this conference over the weekend, and there was a woman there from a group, a large physiatry group, and she said, why aren't there more physiatrists here? Because in their area, it's very common, and they're actually the ones that are mostly running the skilled show in that town. So I think it's regional, but certainly there is definitely a push to have people who know this environment, caring for people in this environment. In the past, it was a primary care doc who would do clinic stuff during the day and then go to the nursing home on the weekend or the evening. You can't do that anymore. These places, they're sick people, and you have to be available. You have to know the environment and know all the restrictions to function very effectively. So there have been a couple studies about what they call SNFists, who do this mostly, and they're increasingly specializing. So this is all their billing comes just from the nursing home instead of from multiple locations.
Do you think there'd be territorial type issues where the SNFists would really want the physiatrists there?
It doesn't matter. I mean, there might be, of course. There's always territorial issues, but the bottom line is the people who care well for these individuals need to be there. I mean, this is a really vulnerable population. So I think over time, there's more and more interest in research in this area. We're going to figure out who is delivering the highest quality care, and over time, we're going to say, I think, it's people who do a lot of care in that environment and know how to rehab people. So it wouldn't surprise me if it ends up that initially we thought it would be hospitalists. Hospitalists don't want to be in nursing homes. So they were sort of thrown out there by various practices, and then they came running back saying, no, please no. So I think it's people that can tolerate a lot of complexity with really frail people will be the ones that end up in that environment. And so anyway. Yeah, Lisa. Oh, I have a plan. Would you like to hear it? I actually published it earlier this year. It involves not going to a nursing home. It involves when I become dependent for more than 2 hours a day, because I'm going to get demented. That's what's going to happen to me, because it is just based on everything. So when I get demented and I need more than 2 hours a day of care because of my dementia, you are to stop my Synthroid. Why? Because I need Synthroid to live, and that will be my end, because I have no children, there will be no natural caregiver for me, and I don't want to burden anyone or the system or spend finances on caring for me after that point. It's my plan. I've thought an extremely long time about it, and so that's my plan. There you go. You asked.